Hello, everybody, and welcome to our second session. We are so happy to have you join us, and that was such an amazing first session to start off with, and to hear everybody talk about their perspective of how to move this work forward. I'm really incredibly excited by this next presentation and this next panel. We have some amazing pediatricians with us, and I can't be more excited for how this is going to go and for this session. So I would like to just first introduce our panelists for today, and then we're going to just start diving into some questions and some discussion in particular around how pediatric clinics can do small and big things to help support our families. So Marjan Linnell is a pediatrician at the Austin Regional Clinic. She's also a member of the ARC's task force to bring the hunger vital sign screening to clinics, and was a member of the Central Texas Pediatric Trauma Learning Collaborative. She also serves on the Texas Pediatric Society Committee on Nutrition and Health. So Anu Partap also has been a pediatrician for over 20 years. She began her career in Phoenix Children's Hospital, Maricopa Medical Center, where she completed her pediatric residency and chief residency. During her time in Arizona, she practiced in safety net hospitals and clinics, school-based clinics, Native American health clinics, and co-launched a private practice and a charity clinic. She also served, and Dr. Partap, I often think, wow, every time I read your bio. And she also served on a variety of appointed governmental advocacy and professional society commissions and advisory groups. And Texas was lucky to have Dr. Partap come and join us in 2009 when she joined the University of Texas Southwestern Medical Center to focus her work on improving health outcomes of children affected by abuse and neglect as medical director of the foster care clinics at Children's Medical Center in DFW. And from 2009 to 2018, she expanded and redesigned the foster care clinic and medical education services with the launch of the state's first multi-pronged integrated foster care health center, and that's the Reese Jones Center for Foster Care Excellence. She served as a consultant to the Health and Human Services Commission on foster care health policy, including design and implementation of the state's new medical evaluation foster care requirements in 2017. In 2018, she returned to prevention work and became the physician director of the Center for Prevention and Child Abuse and Neglect at Cook's Children, and is the medical director of health equity at Cook's Children's Healthcare System. Valerie Smith is a pediatrician at St. Paul's Clinic in Tyler, Texas, which is focused on providing care and support to economically disadvantaged children and children in the foster care system. She is the co-founder and chair of the Smith County Food Security Council, and she's an executive board member of the Texas Pediatric Society and currently chairs the Committee on Foster Care. In addition, she serves on a variety of committees for the American Academy of Pediatrics and the Texas Medical Association. So thank you all for joining us. It's so lovely to have all of you. So I'm going to kick this off by just first asking Dr. Partap and Dr. Linnell, can you explain the purpose of the Central Texas Pediatric Trauma Learning Collaborative and the work that you guys have done through that collaborative?
Glad to, and thanks for inviting us. I think I speak up for all three of us. We're all three friends and excited to do this together, and we all are just appreciative to have this time together, and with all of you that have joined today. And Dorothy, thank you for the invitation. Mm-hmm. You know, the Learning Collaborative was a brainchild of the Texas Pediatric Society leadership, along with St. David Foundation, and to allow a format where we could have pediatricians learn from their peers. How do you take on this tough task of addressing ACEs or adversities in general and social determinants of health? And so the intent of the Learning Collaborative was to bring together a group of pediatricians from Central Texas and create a brand new pilot curriculum, really, with 10 other leaders in pediatrics, but also folks locally, because we're all leaders in our local communities, right? And the idea was, how do you create a safe space to have open dialogue about how tough this is, meet people where they're at, and anticipate the barriers they might face. But through that, move us all through a step closer to asking those tough questions in a supportive way so that families can take better care of their children. So it wasn't very prescriptive, but it was meant to be a structured learning collaborative. So you left the collaborative feeling supportive and more prepared on how to meet the needs of your families in your clinical setting.
So I actually attended the collaborative as a learner instead of as a leader, and I wasn't really sure what to expect. I'd attended some trainings on ACEs and social determinants of health before. I was familiar with the concept, but I'm a pediatrician in a large multi-specialty private practice group, and sometimes I felt, as fabulous as the lectures and the trainings were, I would leave and kind of think, okay, but what do I do now? What do I do with this? So I was really excited to kind of move past the theory and the definitions and take something tangible that I could use in my clinic with my patients and kind of help some of my other partners use it. And so I think the thing that was really the most helpful from the collaborative for me was, just like Dr. Partap said, sitting in a room with several different local pediatricians, almost just coming up with a resource list together. So, oh, I've experienced this and I've heard of this local group and they can help with this. And oh, your patients don't have money for a crib or a car seat. And at the end of it, I left feeling really comfortable, not just with the concepts, but specifically with all sorts of different screeners, which was, for me as a pediatrician, not having used some of the larger screeners, that was really helpful. So then we could kind of sit back and decide what to do for our clinic and what would make the most sense for our patients. But at the end of it, I also had a huge resource list that we added to each session. So when it ended and our patients screened positive, I actually had something to do. I think for so many practitioners, that's the hard part. We know it's important to screen, and then we just look at each other and say, I'm so sorry about what you're going through. Well, what do I do after that? And that was such a key take-home point for me.
Yay.
Awesome. So Dr. Smith, your clinic has an unusual start. It started off as a community closet and a food pantry, and then it brought in clinical services later. So it's totally within your clinic's DNA to provide assistance to families. So beyond the fantastic food service work that you've done, which I want to let everybody know that on the, we have several links scattered throughout the network, as well as on a few of our other websites. A link to Dr. Smith talking at Healthier Texas about the Hunger Collaborative in Smith County. So if we move beyond that, can you talk about the other things that your clinic does to help support families?
Thanks, Dorothy. And I just echo Anu's sentiment about how nice it is to be able to have this conversation with my friends and colleagues, and just how important I think it is for us to be talking about social determinants of health and how we can better serve our patients, and really as pediatricians, how we can better connect our families to resources. So my clinic was not a part, we are not in Central Texas, right? We're in East Texas, so we weren't a part of the Central Texas Trauma Collaborative. We have actually had the opportunity over the last several years to be a part of a program of the Episcopal Health Foundation called the Community Centered Health Home Initiative. And it really challenged us to look at both how we could address social determinants of health within our clinic setting and with the patients that we were seeing, as well as looking at how we could be a driver as a healthcare organization and as a clinic for making community-wide change. So as we started that process, one of the things that I think was incredibly key for us was training all of our staff on social determinants of health and the realities of the world that many of the families that we are caring for take. So we didn't just send providers to training, we actually brought training into our organization, and we trained everyone from the front desk clerk to our biller who has to call when people don't pay, right, aren't making their payments, to all of our providers and medical assistants. And I think that was really key for starting that kind of mindset shift for our organization and recognizing the realities of that so many of our families face. And then we developed a screener, and I think it is on that resources as well that Dorothy just mentioned. We developed a screener that screens on social determinants of health. So this is not an ACEs screen. It asks questions about food insecurity and housing stability and transportation access, childcare, education needs, and developed with a social worker a set of written resources for families. But I think what has been really key is that we were then able to bring on some social work interns, and we actually now have a full-time social worker on staff who, when a family screens positive for one of those social determinants of health, can connect them with resources, make that warm handoff, can enroll them in SNAP or Medicaid, other programs that they may be eligible for, and then follow up with them. I don't have time in a 15-minute clinic appointment to do that work. And that work was, I think, is incredibly important to starting to address those pieces of stability, and recognizing that we don't have to create all of that programming within our organization, even though my organization does provide people with food and clothing and other material resources, that we are not going to be the connection for the solution for all of those things, but that we really can help provide those connections. And then the last piece that we were able to implement over the last few years is bringing on an LCSW who is providing integrated mental health care in our clinic. What we recognize is that the impacts of toxic stress on the families that we serve are real. And I want to just take this moment to echo something that Sasha said in the last session, and that is that my unit of care is the family, it's not the child. And so having an LCSW on board who can help support families and children and provide those behavioral health services has been really transformative for our organization.
That is amazing. And so one of the things I also wanted to talk to you about too, Valerie, is the work that you guys have been doing on becoming trauma informed. And you're the foster care clinic for East Texas. You receive, I believe you're the only provider that accepts in the Tyler area. I know you're the only provider that accepts the health insurance for foster care kids. So a lot of them come to you. And your embarkment on trauma-informed care and how you moved out of just providing it to trauma to your foster care to move it to become universal. Can you talk about that a little bit?
Yeah, absolutely. And I will say our FQHC also accepts Superior Health Plan's Star Health, which sees kids in foster care, but we had found ourselves seeing a significant number of kids in care and had done a lot of again, the medical providers, the other pediatrician or nurse practitioners had done a lot of CME and training and gone to conferences on trauma-informed care over the last 5-6 years. But what we started about 1.5 years ago, we went through an ECHO project with the American Academy of Pediatrics that in many ways I think mirrors some of what the Central Texas Collaborative did, in that it really challenged us not just to think about those kids who we already knew had ACEs or had significant trauma, but how we should approach this with everybody. And so we went through a process, and I loved some of what was said in the last session. We started with having a secret shopper. We had a couple of actually our staff members whose patients are also, or whose kids are also patients, come through our clinic and keep a log and document what their experience was like as if they were somebody who'd never been there before. And that led us to make some really small, but I think significant changes in the physical aspects. We have glass on our front door now instead of a big solid front door, because kids didn't know what was on the other side of the door, right? And it feels like this big scary place. And we rearranged where some of our staff were, and things, really simple things like that, and putting messaging up. And then we did the same thing in many ways that we had done related to social determinants of health, but we had our entire staff go through trauma-informed care training. And that, again, from the person who's answering the phone to the medical assistants. And what we really wanted to do was identify those things that we could have, that our staff members could do that didn't cost anything, that didn't take any more time, but that could really help support those safe, stable, nurturing relationships that are so critical for families. So we have focused on 3 steps. And again, these are not expensive. These are not time. These aren't things I can bill for, but at the same time, I think they really are making a difference for our families. And we employ these for all of our families, not just for those families that are in foster care. So our 3 simple things were, we started by increasing choices for families and kids. So whether it's which room do you want to go in, which arm do you want your blood pressure taken from, which finger do you want me to poke if you need, if you need poked, which ear do you want me to look in first, giving families and children specifically some sense of power and autonomy as they're in this situation that can be really scary. And then our second thing that we focused on was identifying family strengths. I think it was, I can't remember who in the last session kind of mentioned this idea of whether it's just, we're so glad you made it here today, or for the family who's not ever been on time, oh my goodness, you got here on time today. That must have taken a lot of work on your part, right? Kind of recognizing those pieces. To my favorite one personally is when I walk in a room or start to do something that scares a child and they look to their parent or caregiver who's there with them, acknowledging that and saying, you know what? She knows you're their safe person, and she just looked at you because she knows that reassurance from you is important, and reaffirming that. And then the third one that we asked our staff to start doing, and most of our providers had been doing this really through our reach out and read model, but we asked all of our staff to start looking for ways that they could model serve and return for families, whether that's the MA who's weighing a kid, and the kid tries to reach up and grab their name badge and saying, oh, look, you've paid it, you're interested in my name badge, yes. And then kind of pointing out and drawing the parents' attention to that as well. But looking for those opportunities. Again, those are not things that have made huge differences as far as the length of time it's taking us to see patients or the cost. But what it means is that we're supporting every family who comes in, and giving them strength and identifying those things that they're doing well.
That's amazing. That just gave me chills. Dr. Partap, I want to bring you in on this conversation because you and I have had quite a few conversations about universalism and universal health. And so what Dr. Smith is talking about is, universal, that also, it means the entire clinic is trained, and then every family gets this kind of help. And I just want to bring you in on this conversation and this issue of universal help and how you guys have been addressing that.
Yeah, no, thanks. It's a great question. And yeah, I loved listening to Valerie describe all that because you can picture it, right? And it feels so good. And I'm like, I want to go to your clinic. So it's kind of like that. So, and I love my PCP in case she's on. But, I think with universal health, it's that, if you were here yesterday, anyone, you heard us talk about, Dr. Shankar talk about lead and cancer. The interesting thing with adversity and social determinants that are risky is that it's like 30% of families, right? Or for mental health, it's 25%, 20%. The numbers are so high, it becomes sort of silly to think, well, I'm going to first ask you a question and you have to decide to share something with me before I actually give you any information. Like that entire traditional delivery around this particular topic doesn't work. It doesn't really hold water. So what makes more sense is really to make sure we in pediatrics can be the point of contact to say, here's all the help that's out there for you, should you ever need it. Or with our partners to all agree, as a community, we want to make sure every family is aware, here are their go-to reliable, accessible information points for help. Because if you are well today, it doesn't mean tomorrow's not a disaster either, right? And so there's no way to know exactly what's happening 24/7, no matter how close we feel to our families. They need to have that independence to self-help and take care of their children. And that's really our role. That's why you go into primary care, is to work with parents to raise their children. And so I think as we do a better job with ACEs and the social determinants, the more we can remember to just equip every family, the better we'll do. The only thing I would add to that that's a little bit deeper than just going universal is that if there's a positive flag, there's a developmental delay, you notice a concerning interaction, you're looking for serve and return, you don't see it, There's a postpartum depression screen that's positive. Part of our differential diagnosis has to include the other 10 adversities and the other 15 at-risk social determinants of health, or the general environment of stress because of what's happening with the pandemic or the election or the person you knew got shot yesterday next door. You know, whatever it is, you don't know, but we have to probably be more intentional in asking our differentials about the etiologies of some of the things that we routinely diagnose. Every time we hear ADHD, is it ADHD or is it PTSD, anxiety, a bad week at home or a bad year at home, whatever. So I think there's also a universalism to broadening our history taking and our differentials with commonly diagnosed problems in clinic. So kind of two layers to it.
Dr. Linnell, you want to add some things that you guys are doing at the ARC? Because ARC has been incredible with social determinant screening. So
we've really been working on it. So one of the things that came out of the Central Texas Trauma Learning Collaborative, one thing that was really helpful, I already mentioned the local resources, that was key. But the other thing that I think for me was key is that 4 of my pediatrician partners also attended. We were each at a different Austin Regional Clinic with, variable patient populations. But that was really important because then I felt like I wasn't tasked by myself to leave with this big thing and translate it to, we have almost 70 pediatricians and nearly 24 clinics scattered all over the Austin area. Some clinics, including my own, have nearly a third of, Medicaid and CHIP and lower income families. Some clinics don't have any at all. Some clinics have 6 pediatricians, some have 1. It's so variable. So one of the things that was really helpful was that we kind of had a representative from all over Austin in the 5 of us. With our task force, we kind of sat back, we reviewed all the screeners that we had learned about. We're already screening for postpartum depression, and we have a pretty robust system to screen, adolescents for depression and anxiety as well. So we thought, what makes the most sense for us right now? What is tangible? What can be, what can we teach others easily? And what can we get a resource list for to where we can first kind of use it as our pilot model almost. So we looked at the hunger vital signs. They're quick. They're in dozens of different languages and they're validated. Also, kind of like you guys are mentioning, are you exhibiting ADHD symptoms at school because you've not eaten? Or are you exhibiting, there are so many multifactorial things. I can try to control your asthma as great as I can, but if your parents or your caregivers, your grownups are having to decide who gets to eat that day, fairly certain, even if your inhaler costs you $6 to $8, that's not going to be picked up that day. There's so many things that we do in the clinic, and if a child is hungry, it almost doesn't matter. Not to minimize what we do. So we figured this is where we're going to start. Each of us kind of looked at different ways of screening. So we did a couple of months of pilot projects. Some people asked in person. Some of us had it on a handout. Then we worked on a resource sheet. Each of us kind of did something different. So I was tasked with talking with our local food bank, the Central Texas Food Bank, and learning about existing resources because they're there, but a lot of doctors' offices practice in silos. So why we know they're there. Let me leave my office and go to the food bank and ask them what they're doing. So we came back together. We decided it seemed like one of the most successful ways was having it written down and not necessarily being asked. That way, if a family, kind of like Dr. Partap was mentioning and Dr. Smith as well, the ball is in their court. If you don't want to answer these questions, you don't have to. At the same time, we worked on a couple different versions of the food resource list and kind of wanted it to be really easy for families to use. So if you need food today, you go to this part of the list. If you want help signing up for SNAP and WIC and Medicaid and seeing if you qualify, you go here. We also added after everything with public charge, we added some Texas Rio Grande legal aid information for anyone that was worried about signing up for these. And we offered big ones with all sorts of colorful vegetables to grab the eye laminated for anyone in the clinic. So if the family doesn't want to talk about it, or it's not a problem now, but it was a problem last week, maybe they can just snap a picture of that resource sheet and have it if they need it, or share it with someone that they know that needs it. So through all of that, we then we obviously approached our bosses, and thankfully they were like, yeah, screen everybody, teach everybody. It's really helpful to be in a supportive network. So As of about 3 months ago, every single pediatrician at Austin Regional Clinic has been trained on their hunger vital signs. They're also included, we have a form that we give out, a little questionnaire to every family in both English and Spanish. Every family that sees any pediatrician at Austin Regional Clinic for a well check, and the questions are at the bottom of the form. If you think this is something that you want to talk with your patients about or screen, we've also given you all of the resources to do so. Because I think we as pediatricians and, pediatric providers at the end of the day want to do the work, but the really scary part is not knowing what to do when someone screens positive. And so sort of related to that, as you mentioned, I'm really lucky. I'm one of the co-chairs of the Texas Pediatric Society Child Nutrition and Health Committee, which is where food insecurity resides. So we kind of took a step back and looked at this too and said, again, why isn't every pediatrician in Texas asking these two simple questions? They're validated. They're in all the languages. So we took the resource sheet, and with the help of our awesome members and other co-chair, actually have a resource sheet that's specific to basically each of the 21 food banks that serve Texas. So if any Texas pediatrician wants to screen, we have a resource to where they can do so.
And to everybody who's in the audience, I'd also just like to say that the hunger vital signs and the overview checklist that showed the evidence behind the hunger vital signs was actually sent out to everybody in our resource packet as well. So don't miss that. The issue around hunger is also incredibly important because COVID has made it very clear that we had millions of people literally on the edge of hunger. And so that has raised all sorts of issues, not just around food security, but also whether or not collectively we're all experiencing a major adversity. So I would like you guys to talk a little bit about, one, this issue of how COVID has really impacted pediatrics and your ability to help families. And then I have a follow-up about the families. So if you guys could talk a little bit about how COVID has kind of changed your practice and affected the way that you're interacting with families. So Marjan, let's start with you on that one.
Sure. So we did our training at our pediatric department meeting about 2 weeks before everything in Texas shut down. And it's so great that now every child that comes to our clinic will be screened for food insecurity. And if parents want to talk about it, because that's an additional question we asked, do you want resources on this? Even if it's positive, if you don't, that's fine. That's not my place to, let you know that you need them. But to do that, we need patients to come into our clinic. And in the first several weeks of COVID, that wasn't happening. So I know it's out there. I know it's increased, but they're not here. How do I find them? Thankfully, our clinic was really able to come up with some creative solutions. We have several clinics that actually aren't open on weekends typically. So a lot of us started offering well child check sessions only on weekends at clinics that don't see sick patients and don't have our urgent care hours, so families would feel safe. We offered it with telemedicine as well for some well child checks that didn't need vaccines or other reasons to come into the clinic. So with that flexibility, we were able to get more, but I know we missed so many patients. And at the same time, all the families that lost health insurance that was provided through an employer, they're still not coming in. We're trying to figure out, how many are we missing? On the flip side, I will say, as much as I would hope that every pediatric provider in the state of Texas is thrilled about screening for social determinants of health, at the end of the day, I know it's only one of the dozens of things that we have to screen for and check for in a 15 to 20 minute well child session. And at the same time, it's not reimbursed right now by most Texas payers. So an incentive that may have been there for folks that are slightly more hesitant is not. So the silver lining, I would say, of all this pandemic mess is that I do think for several folks in our clinic and hopefully across the state of Texas that maybe thought, well, my patients are in a more affluent area. This isn't a problem for them. This isn't a thing that's happening to them. The sheer number of folks that are having to access services that they have never needed before, I think has really highlighted the importance of it. And we're hopeful that between providers now seeing, even those that were more hesitant, seeing why it's so important and having a resource list for them, that we can really highlight why this is something that needs to be done.
Dr. Smith, you want to jump in?
Sure. Our experience, I think, was very similar to Marjan's, and really, I think, indicative of pediatricians across the state, in that from mid-March for quite some time, we didn't, the numbers of kids who we were seeing just plummeted. And part of that is because kids were at home, and so they weren't at school getting sick with each other, right? So that didn't shock me. I went almost an entire month without seeing a case of gastroenteritis, which is like not a thing in the world of outpatient pediatrics, right? Because they weren't at daycare, they weren't at school sharing those germs. But then what we saw very quickly too was that there was a real plummet in well child exams, and especially I think we had less of that in my community in Tyler than many of our large cities did, where really it made sense in some of those early months not to be accessing healthcare if you didn't absolutely have to. At the same time, our food pantry saw like a 435% increase month over month for April and May from the previous year. So we again, because we straddle both fences and we provide social services as well as healthcare, we really saw the impact very acutely of what was happening. I will say pre-COVID, we had started to see a creep up due to the oil economy in Texas. So where I am is very dependent on that. So we had already started to see a little bit of increase just because that had really been suffering for several months, even pre-COVID. But that need, we have all seen the pictures of the food bank in San Antonio on the national news with lines wrapped so far, where you're in line for 6 hours to get a box of food for your family. What I think that has driven home to me isn't just that people need food, because we obviously know that, and obviously my organization has been working on that in a lot of different ways over the last few years, but it's just how fragile the safety net is for the majority of families in our community. And families that we don't assume it's that fragile for because they've got two parents who are working often, right? Or a full-time job that's a decent job. And so I think it has really created an opportunity for us to have a discussion about how we can, that broader safety net that we can help provide for families and support for families. I will say I'm thankful to report that for the most part, pediatric visits have started to increase, and for most of my colleagues, I think we are back to our typical baseline at my clinic, but most of my colleagues are reporting close to that, some of whom had dropped to a third of their normal visits, right? So I do think people are getting in. Pediatricians, we flipped upside down. Marjan gave a great example. My clinic split our building into a sick side and a well side so that the two don't cross. Pediatricians are working constantly to make sure that children can safely come and get that care. I will also add that telehealth worked for a lot of people. It did not work incredibly well for my patient population. They have real barriers to internet access, device access, and just the technology piece on our platform of how you join and all of those pieces. And so I think we really need to recognize that this didn't impact everybody and every location the same.
Dr. Partap, how did you guys at Cooks work through this?
Yeah, it's interesting listening to these guys. They've really covered a lot of what the experiences were because, at its heart, pediatrics is still a cottage industry, right? So each practice and each provider within the practice really sets the tone and the ability of what they can do. What COVID did was some things just had to be the same, right? But with a large health system like Cook Children's, I don't see patients here, so I can tell you the perspective of what I noticed. And give a community perspective. The practices within Cook Children's and even in the surrounding areas, some could still see patients, some had age cutoffs of who they could and couldn't see, and some could pivot to telehealth. Mm-hmm. But COVID was also a risk to staff. And so a lot of those decisions were driven by, can I keep my staff safe? Can the women and men working in my clinic, are they going to take COVID home to their own families? And so for the first time, we were all dealing with a condition not only affecting our patients, but affecting our own teams. And so that drove a lot of what you couldn't do. In terms of food, which was the original question too, was I started getting calls right away from community partners who knew of a grandmother, a mom, a dad who was out of formula. And I was like, sure, we were going to have COVID rickets. Like I'd already labeled it. I was like, there's got to be an ICD-10 code for this. It's going to happen. You know, thankfully, I don't think that's happened. But it was this moment of sheer panic. Like, how are these families going to have formula? Because in the pandemic early phase, and even, you know, probably in the first quarter, the differential impact on communities based on either race, ethnicity, income, living in dense or rural environments, whatever, really played out. So doing a drive-by formula distribution or food distribution worked for some. Others were not going to take the chance of leaving their house. And so to the credit of this community in Tarrant County, we'd already had an ACEs task force at a county level. And it wasn't the task force itself that did something, but allowed a network of partners who'd met to somewhat in crisis reach out to each other for support and ideas for the families that they were reaching. And I'm just so impressed of watching the sort of wildfire spread of information sharing. We could really quickly lean on Help Me Grow, or here are the flyers, here's the brochures, here's the next event. United Way stepped in a massive way in trying to organize food distribution across partners. Morris Foundation did the same thing, looking at our homeless shelters. And there was a group called Community Frontline who just started driving food to families who were not going to leave their house and take that risk, right? And so as a health system, this kind of speaks to what was said earlier, is none of us can do this alone. I mean, it really reminds me, even as a big health system, we need to do our part to keep people safe, be there when people are sick, and provide the unique service we provide. And then make sure that we connect and lean on the other people who've been doing great work for years and decades, and somehow interweave everyone together. And I think that's ultimately what's going to save us with moving upstream, right? With ACEs and social determinants, is how well can we weave? Because food is just an indicator. It's like the equivalent of your temperature, right? So what else is off? And feeding a child is obviously first in that family, but if the ongoing stress is affecting brain development and stress response and setting pathways for asthma and chronic disease and mental illness and other things, then food alone is not enough, right? And so how do we take all of what COVID did and taught us to say, okay, in addition to food, let's get that right, but let's move up a little bit. And how does that mean we need to help this caregiver buffer their children through everything else? And so I'd say that to say there's still work ahead. I think as proud as I am of everything you've heard and how well the community across the state has really rallied the best they can with families. Yeah.
So yesterday, and with what you guys are talking about right now, there was a generalized theme of one thing that Jack talked about was pediatrics being part of the bigger community. And each of you have been talking about that, whether that's the community across all the clinics within a large system or the community at large. And so I'd like you to talk a little bit about how you build those interactions and how you build those bridges, because you guys have been doing that for a while. And I do know that when I talk to other providers across the state, this becomes a big issue of where do I start and how do I start building these bridges into these other community-based organizations and these other support systems so that we're part of a whole community. So Dr. Smith, I'm going to put you on the spot and start with you.
So you're 100% right. That is such a key thing, and I feel really, really fortunate that I didn't start that for my organization. It was in the DNA of who we are before I got there 15 years ago, and so that's a little bit of a challenge to answer in that respect. But a few things that I think I've learned along the way that I think are really key principles and guiding principles for me. First of all, is that there is often a tendency for healthcare to come into another space and to want to solve the problem.
Mm-hmm.
We are problem oriented, right? This is the medical model, right? We identify a problem, we come up with a treatment plan, we give people, write a prescription, give people instructions, whatever, and move on. And so really having to be thoughtful about listening and learning. I think my work in learning about the child welfare system is where this is really striking, or was really particularly striking to me, and not assume that A, I had the solution, or B, that I was responsible for coming up with the solution necessarily, right? And so I think having that piece of humility and respect for the work that's being done in those other sectors is really key for healthcare providers and professionals and the whole healthcare system, as we really have these conversations about social determinants of health and early brain development and child prevention. And then the other thing I would say, I feel like I'm super fortunate in many ways to be in Tyler, where it's a large enough community to have resources, but at the same time, a small enough community to feel like a small group of people can make a real significant difference, but is really identifying where those groups of people are. So for example, in East Texas, we have a group called the East Texas Human Needs Network that is a coalition that's really looking at social drivers of health and issues that are impacting families in poverty. Transportation is a huge one in our area, for example, housing stability. And so really joining in that work and becoming a part of what was already happening, again, instead of necessarily trying to create that. We did end up creating a food security council that my organization is the backbone of. Part of that was because food was not a part of the work that Ethan was doing. And so we wanted to kind of complement the work that they were doing already, rather than kind of compete or take away from that work. I know so many coalitions, or so many communities around the state have Healthy Mom, Healthy Babies coalitions. That's a really great place for pediatric providers to start to get connected, and other kind of coalitions where you go one place, but you really start to build 18 different relationships, right, during that experience.
So Marjan, I'm going to move to you on this.
Sure. I just to really kind of echo what Valerie said, I think it is so important to show up in places where a healthcare provider may not necessarily have shown up before, but to show up humbly. I think sometimes we get there and, oh, well, there's a doctor here, there's a clinician here, and this is what I do in my clinic, and this is how I think you should do it in your clinic. I really like to show up to places and say, hey, what do you wish pediatricians would do? Like, what is it that when you go to your pediatrician as a family unit, what would help you? Do they ask you about this, or how would it be more helpful for you to do this in a certain way? So I can't overemphasize the point of just showing up. And then additionally, I got to give a shout out to both Anu and Valerie. And I think one thing that's been really key for me has been finding your people and finding a network like the Texas Pediatric Society, because through that, I've been able to express my interest. So I really am interested in food insecurity, or I'm really interested in making sure that, children with developmental delays have access to early childhood intervention. And then awesome mentors like Valerie and Anu will say things like, hey, have you heard of this conference in DC where it's hundreds of people that are interested from all different aspects of life in screening for food insecurity, not just a pediatrician only conference. So I really can't overemphasize showing up, but showing up humbly, ready to listen. And really the first questions out of our mouths should not be, let me tell you how I do it, but it should be, what should the medical community be doing and how should we be involved? There are so many things that I respectfully ask if I can attend and show up to, and they hear, wow, we've never had a pediatrician here before.
I will, before Anu goes, I'm going to add one more thing, and that is that I do think that we have kind of the elephant in the room regarding that is that we get paid for the patients that we see. Right. That is how pediatricians not only take their own paychecks home, but keep the lights on and pay their staff. And right. And so it can be really challenging as somebody who wants to be doing that work to carve that time and that space. And so I think for my organization, I know a huge ability of ours to do that has been some financial support from philanthropy, from the Episcopal Health Foundation and the ETMC Foundation in our neck of the woods and some other places. I think that also can come in larger health systems, recognizing the value of that work and carving some time for their providers in that space. But and then I think the bigger discussion around like value-based care and how this type of work and collaborations could play a role in value-based care, and recognizing that that is something of real need and importance that pediatricians can provide to the community, but they can only do it so much as their bandwidth allows, right? And so I just want to flag that for people who may be in those sectors who are listening, in philanthropy or health systems or funding or payers, that this work takes time, and we have to figure out ways to fund that time.
Anu, you
Yeah,
have so much perspective on this.
No, I mean, these guys have covered like really important points. I'm doing something totally obnoxious. I'm going to say, if you are not a physician or a provider on this conference today, reach out to the Texas Pediatric Society and email our executive director. Because if you have a table or a partnership right now and it does not have pediatricians on it, find one. And you can find us through the Texas Pediatric Society or the Texas Medical Association. And they're out there and they really want to help. And believe it or not, a lot of pediatricians are intimidated to just pick up the phone and call. Like, as crazy that might sound, you go into pediatrics to take really good care of parents and their children and to do that all day long, right? And then when things aren't going right for them, you're like, wow, this is really hard. Why isn't this working right? But then to pause and go do that has lots of layers to it. And if they can hear from you, that invitation means the world to a pediatrician. If you're a pediatrician and you're at nobody else's table or Skype or Zoom or however it is you would participate, just cold call. I can't believe how receptive community folks are, because we all care about the same thing. We all want beautifully healthy, full potential children and families having a fabulous day, right? Mm-hmm. And I can say this when we don't have an election result during a pandemic with racial unrest, and we still want that for our families, right? And at the end of the day, it comes down to who you know in your community. And so, and I guess the last thing I would say is just advocacy looks a lot of different ways. If you are a troop leader, if you're on your PTO, if you do something with your faith, you are doing something with adversity and social determinants. And it may not look like it's a screening project in your clinic, but even those partnerships can start to integrate into how you serve your families. And so you don't need to keep those as boundaries, because I think integration has been the big thing you're really hearing, is how do you integrate community into your practice, whether it's virtually, physically, or spiritually. There's a way to sort of not do it alone, I think. So.
Absolutely. I was just on a panel 2 weeks ago where we were talking about healthcare community partnerships. And I love hearing you guys say, just call us. We want to hear. Because it's kind of what we said too. Have you called them? Have you picked up the phone? And so this is spectacular to hear it. And to those community-based partners out there who are trying to build these relationships, my other thing is, if you get a no, try another one. Try another pediatrician, because these three amazing women are not the only three amazing pediatricians that exist in the state, even though they're amazing. There are more pediatricians out there, a lot of pediatricians who really, really care about this and who really, really, really want to figure out how to make this system more supportive to families. So, like I said, you reach out once, you get a no, let's try another, and let's try again. So there's a fantastic question in the question box that I want to ask you guys. And that is about data collection. And I'm pretty sure I've had this conversation with most of you about data collection. And how do you know what you're doing is working? And how do you collect the data to assess what you're doing is working, or even to collect the data to know how to do quality improvement around what you're doing? So I'm going to start with you, Dr. Smith, because you're right below me in this arrangement.
Right. Thanks. So data collection is hard, and it has been a slow process for us. It took converting to a different electronic medical record system than we were originally using, and then getting our social determinants of health screener built into that, which took, to me, that should be like a 2-week thing, and it turns out it's like a 5-month thing to get some right, to get the powers to build those things in. But we are just now really, I feel like, fully starting to collect, at least being able to track our data about which social determinants of health our patients are screening positive for. And then my hope is that now that we've got that built into the system, in years to come, we'll be able to actually track progress with those pieces. But I think the other piece to think about is that we are collecting or looking at data in other ways. So from a QI standpoint, with the trauma-informed care piece and those changes, we actually just have a short, like, half-page screener that a couple of clinic sessions a month will have our staff fill out about, okay, were you able to model, serve, and return today, during clinic visits today? Were you able to identify those strengths in families? And if not, what were the barriers? And sometimes the barrier is, I had a really hard family and I was really struggling to find strengths. And so then we actually had a discussion where we kind of sat through, okay, if this is really hard and a visit's not going well, how are ways to find those strengths, right? And so that is much softer data, but I do think it's really been helpful for our organization, and especially for our staff, to feel like kind of efficacy in that process and that we're making progress. We've not done widespread patient surveys on those pieces because, honestly, I don't know exactly how I would ask those questions. to be frank, I think you have to be really careful when you're asking those questions, because we want this to be organic to who we are and not feel like it's a project or something, a checklist that we're accomplishing.
Definitely. Well, I like that too, because it's not about the patient, it's actually about you, and it's about the clinic functioning. So it makes a lot of sense not to ask the patient. Marjan, how about you guys? I mean, you've been doing quality improvement, so data is pretty central to that.
We have been, but you're describing basically at this point, a dozen things that keep me up at night along with everybody else. So we have asked that anyone that is screening and getting positive screeners add it to, we use Epic as our electronic medical record, and there's an ability to add food insecurity as a problem in a patient's profile, but then, kind of keep it private. So if they access their MyChart or their medical record in a different way, they wouldn't necessarily be aware of it, though we hope that you're having a conversation so they are aware that technically they have screened positive on the questionnaire and aware you gave them resources. But the issue that we are really having is we don't have an LCSW. We don't have any kind of social worker in our clinic. How do we close this loop? We have the numbers. We know we gave them resource sheets. And by the nature of the way pediatric checkups work, my toddlers are probably going to be back in 3 to 6 months. So I can be the closed loop and just say, hey, 3 months ago, we were talking about this. We gave you some resources for SNAP. Were you able to get signed up? What else do you need from me today? But a child who I see for his 6-year checkup, I'm not going to see until next year. So I wish I had more specific data to give, but right now, short of just knowing how many are screening positive, that's actually one of our goals next, is to reach out to some community partners and see how we can help close this loop and have better data.
And I wanted to move to you guys, because you're now in an administrative position. So you're looking at these and trying to get these data from looking at how the functioning across the system. So
yeah, and I've just moved into that role. I was doing community work the last couple of years too. So I think data comes up a lot because the caution with data, so I want to make sure to say this before we run out of time, is that it can only paint the picture of the population you served and who completed whatever it was you asked. And in that, there's going to, in my opinion, be a bias towards the story that it tells. And I think as we do a better job with being aware of screening and asking and documenting and coding, we also have to remember the limits of what that means for the people who didn't code positive for something, right? And so, so I'm going to actually focus on the way you can use data for quality improvement at a practice or personal level, which is, if from an STOH ACEs standpoint, social determinants of health, this is all about protecting brain development and calming those pathways for chronic disease. So you can look at either a chronic disease you manage, pick one, and for 30 days or 60 days, see, am I meeting the metrics I hope for this? And if you're not, what are the factors that might be differentiating who is reading their asthma goals and who isn't, or their immunization goals or who isn't, or developmental screening goals? And it could be that in that you realize, oh, it's because folks were hungry, so that's why this group is not showing up for X, Y, and Z, like to Marjan's point. But I think until you begin measuring your own metrics, it's hard to begin looking at population level data. Those should happen because that's how we improve systems of care. But there's a lot of power in doing a PDSA on your own panel with your own practice. And I did that for 20 years, and I was always not the doctor I wanted to be yet, because there's always something that, I could do better. The last thing I'll say about that is when you're adding something in a PDSA and using data collection can help validate, see, we're not going to break the bank adding these two questions. See, our patients didn't stop coming in, or the front desk managed this beautifully and our show rate actually went up. You know what I mean? So there's a lot of validation in collecting data that we forget. It's not all about the bad things, which is I'm always looking for with my own practice. But I think there's a lot of way to tell the story about the power of the change that you made too. So I think MOC has a PDSA one maybe, but MOC, if you need your MOC credits, look on the American Board of Pediatrics website and you'll probably find something related to adding questions around social determinants for adversity and how to capture change over time to meet your MOC Part 4 requirement. So for the physicians on the call. So.
There's also another question on here about the Healthy Texas. Oh, sorry, this is my anachronistic referral to the system, but the Healthy Mom and Baby Coalitions and how to find the Healthy Mom and Baby Coalitions. And so I just want to say a couple of things about that. Is one, there are Healthy Baby Coalitions through every public health region in the state, and you can contact your regional public health director to find your Healthy Moms and Babies Coalition. Am I saying that right, Valerie? Is that what they're called now? I think so. So you can find the coalition through the public health department. Also, the centralized place to find the coalition is on the Department of State Health Services Title V website. They are providing a lot of the seed funds through these coalitions. So please go there. You can even contact the SHS. Jeremy Triplett is the director of that division that oversees those coalitions. You can contact and reach out to them, and they will let you know who the director and who's the chair of each of the coalitions in each of the regions. So that way you can connect to them and be a part of those coalitions, which are amazing and have been working and existing for several years now. So I wanted, somebody just told me it's Healthy Texas Mothers and Baby Coalition, so I'm good. So please reach out to DSHS and they can connect you to the correct one. And then I think the last question has been answered. So we're good on the last question. I really want to also say how much I really appreciate our partners from Texas Medical Association who are on this right now and who have been doing an amazing job. Thank you so much, Sam Cooper, for answering a bunch of questions for us. I appreciate that. And thank you so much for our TPS partners who have also been on here and who have been taking care of questions for me as well. I really appreciate the work that you are doing. And so I would just like to once again say thank you so much, Anu, Valerie, and Marjan, for being here. This has been amazing. And thank you for all the work that you guys do for kids in this state. I really, really just want to say how much I appreciate the three of you.
Thank you.
Thanks.
So
I think we're
we are-
humbled and appreciate being here. Thank you.
Thank you.
Thanks, friends.
So we are going to go ahead and I am going to end this session, and we're going to move everybody into the next session where we're going to be talking about the Texas Child Mental Health Care Consortium, which we're very excited to be presenting about today. Thank you so much.
Oh, I guess they left us in the...
Oh, it's Jess.
Did they send everybody else away and we get to stay?
I
That's
don't know.
exciting.
I think everyone still might be here, so I don't know for sure. So, but you guys are so good. It was very fun to be with you. So.
You know, it really was like a conversation. That was one of the most fun panels I've ever been on.
Because you guys are awesome. Well, I don't know if it's just the three of us, so I